Hello, everyone, and welcome. I'm Trey Shalley, the Sponsorship Logistics Manager at Rise, and I am stepping in for my colleague Tracy Anderson this afternoon. We are delighted to have all of you join us for today's webinar titled, It Matters to This One, Achieving Better Health Outcomes Through Social Determinants of Health, presented by our sponsor, Centauri Health Solutions. Today's webinar features Dr. Julie Goldberg and Dawn Carter, who I will introduce in a moment. But first, I have a few housekeeping items to go over as well. Questions for our speakers should be submitted in the Q&A box. We will be answering questions at the end of the webinar, but feel free to submit them at any time during the presentation. Today's program is being recorded. We'll be posting a copy of the recording in our member library located in the member portal. We'll be sending all participants a copy of today's slide deck as well as access to the recording. You can expect those deliverables via email within 1 week of the conclusion of the webinar. We do ask that you stay tuned for the entirety of the presentation. This way you will be able to participate in our member experience poll to give us some feedback on your experience today. As a reminder, all attendees are muted and will remain on mute for the duration of today's program. Without further ado, I will hand this off to Dawn Carter, who will get the program started.
Thank you, Trey. Good afternoon, everyone, and thank you for joining today's discussion titled, It Matters to This One, Achieving Better Health Outcomes Through Social Determinants of Health. Now, you often hear social determinants of health referred to in an acronym as SDOH, and may have also wondered why we as an industry should care about it. You might also be wondering why my co-host and I were tapped for this topic. And so before we introduce ourselves for the benefit of those who we might not yet had the pleasure to meet either in person or virtually, I thought I'd take a moment to tell you why we were tapped, aside from the fact that she and I are both very passionate about this topic. Dr. Goldberg is a social scientist whose PhD and work prior to Centauri in academia was directly related to SDOH. And I have been investigating for some time now how SDOH lies at the intersection of risk adjustment and quality, and how there might be opportunities from a product development perspective. Both she and I serve on an enterprise-wide project related to SDOH that is also focused on the potential opportunities for Centauri. Hopefully, this presentation will help you understand the complexity of the topic, and also why it is critical that our industry is able to benefit from any technology or other solutions that we might be able to develop and offer. So, first allow us to introduce ourselves before we start what we hope will be a very enlightening discussion. My name is Dawn Carter, and my current title is Director of Product Strategy, but I wear many hats here at Centauri since joining the company since almost its very beginning in October 2015. My main role is product and business development for risk adjustment, as well as serving as a subject matter expert for the same. And I also provide strategic advisory services for clients seeking to implement or improve their risk adjustment operational strategies to maximize their chance for risk adjustment financial success. As you will soon see, I have lately become involved with population health, social determinants of health, and health equity as a natural step towards integrating these into risk and quality solutions. To prepare me for these roles is 27 years of revenue cycle experience across a wide cross-section of the healthcare industry, such as payer, provider, and government. And because I am so passionate about bringing this experience to bear in the products and services we develop and offer at Centauri, I am also a pretty prolific blogger, content developer, and webinar deliverer, which is why I'm here to speak with you today. And now I'll pass it to my esteemed colleague, Dr. Julie Goldberg, who will introduce herself before we get fully underway. Julie?
Hi, it's a pleasure to be here today. At Centauri, I am currently the product delivery manager for our risk adjustment platform. And as Dawn mentioned, I'm also closely involved in our enterprise level SDOH initiative. But before I started working at companies that are at the intersection of medicine and technology, I got my PhD from UC Berkeley in social psychology, and then spent 11 years as a professor at the University of Illinois at Chicago College of Medicine, where I specialized in the psychology of medical decision-making, where I focused on health disparities research, really trying to understand why it was that specific racial ethnic groups suffered poorer health outcomes, even when we were controlling for all of our established known risk factors. And during this talk today, I'm going to be sharing some of my research findings with you. Now, sending it back to Dawn.
Thank you, Julie. So now we'll get started by advancing our slide to the definition of social determinants of health. Now, it's highly likely that most people in this audience have at least heard of social determinants of health, also known as SDOH, and we know how our industry loves its acronyms. A quick Google search of the term next 206 million, that's million with an M, hits, so it's clearly top of mind for many. And also in the Google, you'll even see that depending upon whom you ask, there can be anywhere from 5 to 12 SDOH. And I just chose to display here the most commonly accepted one from Healthy People 2030. So let's just start off with the definition. According to the CDC and health.gov, SDOH are the non-medical factors that influence health outcomes and are the conditions in which people are born, live, learn, work, play, worship, and age. And what's most important to understand about SDOH is that these factors, by and large, are not addressed as part of a standard biomedical health assessment and are very much qualitative as opposed to quantitative. And that as a result, traditional medical care addresses only about 10% of the controllable contributors that make a population healthy. Next slide, please. So here we have listed the 5 SDOH that are fairly universally agreed upon: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Now, according to a recent report, 68% of health plan members have an SDOH, primarily financial security and isolation, and 60% say they have never discussed this with a provider. And those who do discuss SDOH with a provider are 2.5 times more likely to accept help from a provider rather than an insurance company. Now, given that a great deal of our industry is comprised of payers, who are in turn contracted with providers, all of whom have a vested interest in the health of those they serve, you will soon see why every type of entity in our industry would be so interested in SDOH. When you hear about value-based care and population health, it is important to remember that SDOH is a critical part of these kinds of initiatives, and this presentation will help you see why that is. So now you may be sitting there thinking, wow, Dawn and Dr. Goldberg, are we going to take the full hour of the webinar to solve what appears to be all of the world's problems? The answer would be, we wish, but what we will do is make sure that you understand how we as an industry and we as members of communities all have a role in helping to address these. As consumers of healthcare technology and stewards of data, we have a unique opportunity to develop cutting-edge solutions for entities who are tasked with a better understanding the most influential factors for their members' health, and those factors are very clearly SDOH. I'd like to show you how we've already started doing just that, even if you might not realize it, and to also show you how close to home these factors hit with a personal story. Next slide, please. So let us turn our attention now to a very specific SDOH, one that is very near and dear to my heart personally, as you'll soon see: food insecurity, which is in the domain of social and community context, as you saw earlier in the illustration. Food insecurity is defined as the disruption of food intake or eating patterns because of lack of money and other resources. In 2014, 17.4 million US households were food insecure at some time during the year. So this affects a lot more people than we might realize and is probably now worse due to the stress and isolation of COVID. Our health plan counterparts have realized this, and Humana found that food insecure older beneficiaries are 50% more likely to develop diabetes, 14% more likely to develop hypertension, and 60% more likely to experience a heart attack. 30 million people in the US are afflicted with diabetes. Another 84.1 million adults have prediabetes. This is staggering considering there are about 330 million people in the United States. The costs to the healthcare system are staggering, reaching $327 billion, that's billion with a B, in 2017, not to mention costs associated with loss of productivity and quality of life. We also have to wonder how much of this population is uninsured or underinsured. as are many with whom we come in contact at Centauri through our eligibility and enrollment services, best benefits, and premium assist service lines. I also read recently that 79% of primary care physicians are burnt out. And remember the earlier statistic I quoted about patients not discussing SDOH with their providers. So it is clear that all of this is a recipe for the traditional reactive and expensive approach to addressing negative health outcomes and the subsequent chasing of risk and quality gap closure. CMS is also very interested in the intersection of risk adjustment and quality measures, as evidenced by inquiries into the overlaps of data sets used to calculate both, and most notably, their announcement in the very recently released calendar year 2023 advance notice for Medicare Advantage. In the notice, CMS is soliciting input on future measures and concepts as they continue to advance health equity and enhance the star ratings over time. At a high level, in the notice, CMS specifically is soliciting feedback on the following. 1, plans to enhance current CMS efforts to report stratified Part C and D star ratings measures by social risk factors to help Medicare Advantage and Part D sponsors identify opportunities for improvement. 2, the development of a health equity index as an enhancement to the Part C and D star ratings program to summarize measure level performance by social risk factors into a single score used in developing the overall or summary star rating for a contract. 3, the development of a measure to assess whether plans are screening their enrollees for health-related social needs, such as food, housing, and transportation. And last but not least, how Medicare Advantage organizations are transforming care and driving quality through value-based models with providers to use in the potential development of a Part C star ratings measure. And those are verbatim from the notice. So that's where I got those from. Also, in the very recent past, HHS released their Notice of Benefit and Payment Parameters proposed rule for 2023 for the Affordable Care Act and commercial exchanges. And this notice also similarly advances policies related to health equity for consumers purchasing marketplace coverage. CMS proposes to collect and extract through issuers' edge servers 5 new data elements, including zip code, race, ethnicity, individual coverage health reimbursement arrangement, another acronym here that we love our acronyms is ICHRA, indicator, and a subsidy indicator as part of the required risk adjustment data that issuers must make accessible to HHS in states where HHS is operating the risk adjustment program. So as you can see, we've got something for everybody in this webinar, whether you're Medicare Advantage, commercial, or interested in innovation. So if that's not enough policy for you, the CMS Center for Innovation is doing some special SDOH related testing with the Accountable Health Communities, which is the AHC model. Under Section 1115A of the Impact Act of 2014, the Accountable Care Health Communities model addresses a critical gap between clinical care and community services in the healthcare delivery system by testing whether systematically identifying and addressing health-related social needs of eligible Medicare and Medicaid beneficiaries through screening for HRSN, referrals to community resources, and community navigation services will impact healthcare costs and reduce healthcare utilization costs over a 5-year period. The CMS Innovation Center developed the AHC Health-Related Social Needs Screening Tool to identify needs in 5 core domains: housing instability, food insecurity, transportation problems, utility help needs, and interpersonal safety. The first HC model evaluation report, which assessed 2017 to 2020, demonstrated high prevalence of these social risk factors. All of this recent policy proposal support one clear direction, and that is that health plans and other operating risk and quality programs for Medicare Advantage and commercial exchange cannot afford to ignore SDOH and health equity and must be prepared with solutions to comply, preferably with solutions that efficiently and effectively address both risk and quality. In this graphic, I included the HCCs for each risk model for Medicare Advantage and commercial that pertain to the SDOH of food insecurity. You can clearly see in this graphic that the risk models for both Medicare Advantage and commercial share some HCCs, although the number assigned to them are different. I also included the HEDIS measures that are related to food insecurity, which look very similar to those HCCs as well. We all know what HEDIS is. It pertains to the measurement of the quality of care that members are receiving from the health plan. so you can easily see how it behooves health plans operating in risk-adjusted markets to care about SDOH when proactively addressing risk and quality. And the ROI is demonstrably clear and quantifiable in terms of risk-adjusted dollars from improved health outcomes. And this is just one SDOH. Proactive is the key word here. Our traditional approach has been overwhelmingly reactive, meaning let's look back at historical data and draw conclusions. But as I've shown you with the statistics, this must change, and solution providers must be ready to support their clients with a more proactive approach to managing population health across the full spectrum of clinical and non-clinical products and services. Furthermore, addressing food insecurity often requires more clinical strategies, non-clinical strategies. Clinical, as I mentioned, though the story can be told in the clinical outcomes data, such as claims, quality measures, etc. What if we could help our clients close these concerns? And what if we could even help tailor enrollment and benefit-related activities based on these? The answer is in the data available to target those who are food insecure, and clients can then plan strategies to link those provided resources with their members. Risk and quality gap closure can be achieved as health outcomes are measured. Just as each member in the health plan is unique in their needs related to food insecurity, and a health plan or benefit assistance that serves these needs, health plans also require assistance in accessing and using the data to target the members to close risk and quality gaps while addressing SDOH. Next slide, please. Yes.
Are we on the right slide? There's some questions in the chat that it wasn't advancing. Is that?
We are. We're on the right slide.
And then your audio is going in and out just a little, just to let you know.
Thank you. I want to introduce you to Kayla. Kayla is my 11-year-old daughter's best friend. It's not just because of my job that I recognize some of the more obvious factors in Kayla's life that clearly indicate that she is food insecure and at risk for the chronic illnesses listed a few slides back. Factors such as limited transportation, distance from a source of fresh food, and access to fast food. Therefore, it's not enough for her family to have SNAP benefits. They need so much more than that. It's also obvious that Kayla's family has limited means to get her to a provider's office, even though her Medicaid MCO offers transportation to appointments, and that they spend most of their time at home and in the community. Kayla has a Medicaid managed care plan, and one would hope that for her sake and for those like her, that the plan, through efficient and effective use of available data, has recognized that she is food insecure and that community and home-based interventions are planned to address her unique needs and prevent the manifestation of costly HCCs. Sadly, that does not appear to be the case. At Centauri, we talk a lot about how we measure the success of the work we do for our clients in enrollment and benefits, risk adjustment and quality, and also about how we affect the members served by our clients at the individual level. We can calculate the ROI of gap closures and quality measures management related to food insecurity to see it. Kayla serves as an example of someone whose life could be changed so much for the better through good data stewardship, and the resultant ROI of that increased health and happiness is incalculable. However, as Dr. Goldberg will soon discuss, it's not just the payers or government's responsibility to care about Kayla and those like her. It is also the community's responsibility to care about the least among them. During COVID, when schools were shut down, it was particularly awful for kids like Kayla, whose only meal on the weekends might have been the backpacks that our local churches fill with food and take to schools for distribution to the kids that need them. But with the schools closed and the global pandemic and fear of infection, how would those kids get those backpacks? It broke my heart to know this. And because I know all too well where many of these people live that are food insecure, I would go to the grocery and dollar stores, fill upon bags with food, and drop them under the cover of night on their doorstep so they would not know it was me. I also work on community initiatives designed to address food insecurity, such as the Sunshine Food Bus and others, which bring food to those who need it, because I know that this is what it is going to take to do my part. Professionally, I can do my part here at Centauri in product development by helping to explore how we can support our clients in doing their part. And this is just for one SDOH. Sadly, there are more that pertain to Kayla. Let's do our part to make sure Kayla keeps that smile on her face despite the odds against her. Let's give her a fighting chance at a healthy future free of the burden of chronic illness. She's worth it, and we're worth it. And now Dr. Goldberg will continue our discussion with some theory and some other exciting content. Dr. Goldberg?
Thank you so much, Dawn. Now, because payers recognize the importance of stories like Kayla, and as Dawn has mentioned about the new CMS initiatives, there's a great deal of interest in offering SDOH program for the 2022 Medicare Advantage members. United is offering a U card that has over-the-counter and food benefits at 30,000 different retail locations, as well as in-home visits with a social needs assessment. Anthem's Essential Extras offers a flexible spending card that can be used to buy dental, vision, or hearing related items, as well as a healthy groceries card, including, in addition, in-home support for things like housekeeping, errands, technical support, which I can totally tell you my 85-year-old mother can use because she thinks I'm her technical support. They also offer transportation, meal delivery. Cigna has a social connection program that provides assistance with key activities of daily living, like transportation, meal preparation, and chores. And Aetna has a new food benefits card. And this represents the pretty standard approach to incorporating SDOH into healthcare, this sort of buffet of services or referrals to all eligible members. And Centauri is among them. Between our Social Services Plus, Resource Connect, and Benefits Plus programs, we also perform needs assessment to identify specific social service needs around food, utility, housing, transportation, financial assistance. And then we provide this referral information to our eligible members. And this looks great, right? More information, more choices to more people. But the sheer number of choices that we all face every day can be overwhelming. Starbucks proudly advertises that when you make a selection for your coffee drink, you actually have 80,000 different choices, from the country of origin of your coffee bean, to the type of coffee drink, a macchiato, cappuccino, to the type of milk you want to have. And you can see in this cartoon, of course we can make fast decisions once we've considered the 4,872 factors. Now, these choices become exponentially more overwhelming when you're living at the intersection of multiple SDOH factors, like food insecurity, combined with unstable housing, unemployment, and then add to that an unexpected illness. When your house is on fire, how do you choose which of 30,000 retail locations to use one of two different benefits cards for which services being offered to you? In psychology, we call this phenomena choice overload, or too many fish in the sea. People think they prefer more choices, but as you can see in this picture, with so many fish in the sea, how do you justify picking one? And paradoxically, what the research has shown is when we present more information and more choices to people, the less likely they are to make any choice, resulting in decision delay. And once you make a decision, decisions that are of poorer quality, with which we tend to be less satisfied, or even more tragically, no decision at all. And actually, Dr. Schwartz has a really interesting TED talk called The Paradox of Choice that gets further into this. And this type of decision paralysis is seen for both low and high stakes decision-making. As an example of low stakes, a grocery store thought they're going to increase their sales by, instead of just offering 6 varieties of jam, they're going to increase it fourfold and have 24 varieties of jam, thinking they're going to really increase their sales. What they found was that when they had 24 different varieties, people were less likely to buy anything compared with only having 6. And you can see in this very cute graphic, when we have a few options, we're good. But present us with so many options, how can I justify picking one jam out of 24? And this type of decision paralysis is also seen in high stakes decisions. As just 2 examples, Direct Care were considering a special needs program, but their willingness to even examine the options significantly decreased with the increase in choices they were presented with. And then when it came to a prescription drug plan, whether you were a young adult or an older adult, the more options you were given, the worse decision you made, the more likely you were to pick the more expensive and less convenient plan. And again, this cartoon captures this. You can see all of these yeses, nothing in the no column. I think I'm seeing a pattern here. We just need to talk to 1,385 more people before we're confident enough to make a decision. And when it comes to your health, there is a very high cost of decision paralysis, because some interventions are going to be less effective if they're delayed and or result in less long-term benefit, or even might not even be available to you if you wait too long and you've gotten too sick. And when it comes to financial cost, obviously the sicker you are, the more costly your care. And when it comes to SDOH, if your situation has significantly deteriorated, it will obviously be more costly for us to intervene. But obviously, we need to give people choices if we want to start changing the chronic habitual behaviors that underlie the social determinants of health. But information about choices, like a list of referrals, that's just the first step in a much larger process. Because if information alone were sufficient, an entire weight loss industry would be out of business, right? If we just needed to be told what was good for us and we could act on it, we'd be golden, but that's not reality. But change is a process, and therefore we need to message to where people are along their path to help them take action. And Prochaska and DiClemente is one of the most robust theories of health behavior change. And they posit that there are 5 stages to change, with sort of an unofficial 6th one. And we all start in pre-contemplation, where we have no intention of changing our behavior. But that isn't necessarily because we're in denial. It may be that we can't even imagine addressing this issue because we have so many other competing priorities. Again, if your house is on fire, don't give me information about 17 places where I can find fresh vegetables, right? At this stage, presenting options could not only be counterproductive, but even potentially backfire on you. At this stage, we need to reframe that continuing to engage in the same behavior time over time is a choice. And if you start thinking about, well, if I'm choosing to act this way, maybe I could make a choice to act another way. And that reframing could move people from pre-contemplation to contemplation, where individuals are willing to consider taking action and making different choices. And there's the buy-in to the possibility of change. But we don't go right from contemplation to action. We actually have an intervening step, and that's called preparation. That's where we start making our plans for change. But here, it is key that these be small, achievable goals, because paradoxically, research has also shown us that if you're too ambitious, that plan can backfire on you as well. And this is called the aspiration gap, which is the difference between where you are now and where you want to be. Imagine a diabetic patient who's suffering from obesity. She's sedentary. She has high cholesterol, high blood pressure. Her joints ache when she tries to move around. And she not only aspires to lose weight, but she also decides that she wants to join a gym and become a triathlete, like my colleague, Dawn. Now that sounds like a great goal, but research has shown when the difference between where you are now and where you want to be is so great, sedentary, obese, in pain versus a triathlete, that discrepancy is so great that it actually prevents you from taking any steps forward. And this aspiration gap research has shown us it's a little like Goldilocks. If the gap between where you are now and where you aspire to be is either too small or too wide, that can result in failure, preventing you from taking any action at all. And it has to be just right. And that's where your aspirations can become inspirational. And my own work with juvenile delinquents shed some light on this, where I wanted to know, does it even make sense to talk about choice for folks who are living at the intersection of every imaginable risk? Now, I was working with kids who had not only committed acts of gun violence for which they've been caught, sentenced, and imprisoned, but they were also the victims of violence and had typically experienced vicarious violence in their own homes as well as neighborhoods. So I wanted to know, would it make sense to implement a deterrence-based program to reduce gun violence on the streets of LA among the gang members? Would this have any chance of working with folks who had joined gangs whose choices had clearly been reduced based on their past? But for deterrence to work, to get them to stop shooting and killing each other on the streets, they needed to believe that their future mattered as a result of their current behavior. So I needed to understand what they thought about their future. So I asked them some pretty basic questions, like how likely was it that they could, I don't know, complete high school or even get a full-time job? Now, half my participants said, when I presented them with a hypothetical situation where gun violence could typically break out in gang territory, they said not only would they shoot first, but they'd shoot to kill because everyone was their enemy and they didn't expect to live past the age of 18. They had no future at all. And this was pretty realistic, given what their lives looked like outside of the juvenile detention center. But what surprised me was the other half of my sample, who said that not only did they think they could talk their way out of gun violence, but they said there was like a 99% chance they'd be able to get their GED while they were in juvie hall and even get a full-time job when they got out, even if that meant they had to leave the only neighborhood they've ever known. But when they were talking about this vision of their future, I don't think it was expectations I was hearing. They tended to take a deep breath, sit back in their chair, and I think they were sharing aspirations with me. But these aspirations could only inspire behavior change if they had the tools and the resources and the realistic steps to achieve them. And tragically, with the pandemic, aspirations among our young people are increasingly becoming unattainable. A recent census in the UK found that 41% of all young people across the country believe their future goals are impossible to achieve. And this rises to half when you're talking about those from poorer backgrounds. But let's say you're able to make these realistic plans and you act on them. Whether your plans are successful are not just based on your plans and your intentions. There are also very real social, economic, and physical barriers you often have to overcome. Things like, do you have the transportation you need to enact your plan? Do you have childcare if you need to leave when your children are home? Can you take time off from work if this has to happen during the working hours? Is there any physical danger to leaving your home or your block or even your neighborhood to implement your plans? As an example of these, when I was working in AIDS prevention, I was working on a project with out-of-treatment injection drug users in North Philadelphia. And one of the young men that I was talking to was committed to completing high school, which felt like a pretty attainable plan. But when he was telling me about how he got his homework done, he told me to sit on the floor of his apartment in the projects in North Philly. And I first thought, well, maybe he didn't have any furniture. But he told me, no, they have a kitchen table. But he sat on the floor so he'd be below the level of the windows so that he couldn't be seen through the windows, shot, and possibly killed while he was finishing his homework. To reduce these real world barriers to an individual's failing is not only insulting, but ethically and morally reprehensible. And you can hear some of this struggle in one of our Centauri members' experience, who had struggled for 5 years to get the benefits that she needed in this recording I'm about to play for you.
Hi, Teresa. Just to let you know, this call is being recorded for quality assurance. My name is Alex. I'm the supervisor of the hearings department. Maisha said you had some nice things to say about Amy.
Yes, ma'am. I want you to know that I felt like this woman really stepped beyond her job title to help me. And like I was explaining to her, she's been a very compassionate woman through all this, and I appreciate all the help y'all have done to help me get here. My biggest thanks goes to Amelia. I guess her name is, the one that was at my hearing. I really want to commend her for her compassion. This hearing was done over the telephone, so I don't know what this woman even looks like. But I want you to know what you got there. That woman's got a heart. I broke down on her during some of this so she could get me prepared for my hearing. And that woman showed me more compassion over the phone the week prior of my hearing. Showed more compassion to me than some of my doctors, some of my counselors. I feel like I was a human being when I talked to this woman. I wanted her to know it, and I want all you to know what you got. Because this woman touched my heart. Literally, and I told her so. I said, I feel like she stepped beyond her job title to comfort me once we opened that bag of worms, and I went to crying and lost it on her trying to talk to her. She handled it more than just professionally. Amy is a wonderful woman. She's done a great job. Y'all beat this for me. I've been fighting it since 2016.
Oh, my gosh.
But I just want you to know that there is some compassion in those ladies' heart. They make a wonderful team.
Hi, Teresa.
You can feel the gratitude in that member's voice and imagine the hopelessness you must have felt for 5 years before we were able to intervene. And part of this hopelessness is due to the fact that when we act and we fail to be successful, we disproportionately blame that failure on ourselves or the individual, rather than the very real situational, social, and economic factors that impacted that. And this is so robust a phenomenon in psychology, it's actually been labeled the fundamental attribution error. And the classic research study asks people to read what are called counterintuitive essays, which are essays which are written that go against your attitude. And they always pick controversial topics like Black Lives Matter, whether you oppose or support them. When subjects read essays that they are told go against the attitude of the writer, and they are told the writer was compelled to write on this subject matter, individuals still overwhelmingly say that they believe the writer held these attitudes. And this is a laboratory study with virtually no stakes. What happens when individuals fail to achieve change in the real world? We blame what we see. We blame the person who failed, instead of these amorphous situational, social, economic factors. And this kind of hopelessness can undermine our ability and our motivation to take any action. But let's say you manage to act. When it comes to the kind of controllable, habitual, chronic behaviors that underlie SDOH, this is not a one and done process. It is crucial that individuals internalize and own this change so they can maintain it over time, because it cannot be a one and done process. And this sort of maintenance step is almost never incorporated into programs. And then there's sort of an unofficial sixth step, which is relapse, which is incredibly common. I mean, anyone who's ever been on a diet knows that you have one slice of cake, you're like, oh, fell off the wagon, might as well eat the whole thing, right? We need to gently and compassionately guide people back to wherever they are along the stages of change, so that we destigmatize and normalize the potential for relapse, which is almost inevitable. And as if I didn't depress you enough with how challenging it is to change, there are two other factors that are particularly challenging when it comes to SDOH. The first is the time lag. There's an inherent delay between when we start a new behavior and we see an impact on our health outcomes. And you can think of this if you've ever started an exercise regime, right? In the beginning, it's actually harder, right? You have to find and join a gym, you have to buy workout clothes, you have to actually work out. So in the beginning, you have sore muscles and you're out the money for a gym membership with no evidence that it's actually working. The second issue has to do with correlation versus causation. When there's this sort of delay between changing a behavior and seeing the outcome, it's really hard to determine what caused it. And specifically for SDOH, how to tie a specific SDOH program to a specific health outcome, like lowered A1C for diabetics, especially if you're implementing a buffet of services, is really challenging, because you can't definitively say necessarily that one caused the other. And this is demonstrated in this cartoon. Another huge study found no evidence that cell phones cause cancer. What was the WHO thinking? I think they just got it backwards. Huh? We'll take a look. You can see here, total cancer incidence is increasing and cell phone users increasing. Just to be safe, until I see more data, I'm going to assume cancer causes cell phones. You're not. There are so many problems with that. And this exemplifies the fact that when two things increase at the same time, you can't definitively say if one caused the other, or they may both have been caused by an unrelated third factor. Another example is in the summer, ice cream sales and shark attacks both go up. It's unlikely that shark attacks cause ice cream sales. However, the summer and people being on the beach are related to both an increase in ice cream sales and an increase in shark attacks. So given all of these problems and challenges of changing behavior, you might ask why payers should even invest in SDOH. If you can't measure your return on investment as tied directly to your intervention, and you might even ask, even if I could measure this, is it my job as a payer to invest in costly programs to ensure stable housing and reliable transportation, especially since we know that insurance is tied to employment And members on average are changing jobs about every 4 years, with millennials changing even more frequently. So even if you were as a payer to invest in SDOH, your member may no longer be covered by your insurance to reap the reward. And that may be why we see an investment at the federal level for a Medicare Advantage population. But these individuals are older and maybe a little curmudgeonly, a little harder to change. So you might get more bang for your buck if you target a younger population who theoretically might be more willing to consider changing their behaviors, but statistically also have more life years that could be impacted by that behavior change. And if Don and I were to put on our social justice hat, by targeting a younger population, we might even target other cycles of crime and poverty, as well as the disease that are associated with individuals living at the intersection of so many SDOH factors. So what can we as health technology companies like Centauri Health Solutions do? And now I turn it back to my colleague, Dawn Carter.
Well, let's come back around to talk a little more about what we can do from a data and solutions perspective. There's a reason that I chose this particular language for this slide, and it is in Centauri's motto that you see here, the power to solve and the passion to serve. Yes, we have a passion to help here at Centauri, as our motto states, but we also have, with our analytical tools that help our clients access and use data, the ability to enable powerful solutions in the SDOH space. There is also a reason that I kept this slide very succinct, because I also know that the best solution is often the simplest, even though there might be complexity in the data that lies underneath. And you heard some about that in Dr. Goldberg's presentation. We know that large amounts of big, structured and unstructured data are necessary to harness the critical insights that clients need to understand population health. And these days, the issue is never the lack of data, it is the inability to access and use it effectively. For SDOH, we are talking about data from the census, from the USDA, from the CDC, big data from too many sources to name. I see this referred to these days as a, quote, advanced data ecosystem, unquote, and I like that. It's also not enough for clients to simply offer a one-size-fits-all buffet of programs and benefits with no way to understand the ROI in terms of healthcare dollars and risk and quality. And this also relates to plan benefit design and the strategies that are implemented for risk and quality. Centauri has built powerful suspecting engines to assist clients in assuring the maximum ROI for risk and quality programs. So it makes sense that the same type of suspecting engine could be built for SDOH and targeting the members who are likely to benefit the most from specifically tailored interventions. We also use emerging technologies such as artificial intelligence and natural language processing and our other solutions that employ engines. So it makes sense that we would do the same for an SDOH suspecting engine and calculate the relative ROI of addressing SDOH on risk and quality gaps. To hear more about how we are helping our clients better understand the unique SDOH of their population and the unique interventions they are employing to integrate addressing them into their risk and quality programs, be sure to join us at RISE National in March when we present on the 9th about the work we are doing together to support health equity and culturally competent healthcare. Next slide, please. So as we bring our presentation to a close today, we just have a couple more slides that demonstrate our passion for this topic and why it's so important. And this, I'm going to read this little, anecdote called "It Matters to This One." A man walking along the beach noticed a child tossing things into the ocean. Approaching the boy, he asked, "What are you doing?" The child replied, "Throwing these starfish back into the water. The sun is up and the tide is going out. If I don't throw them back, they'll die." "Son," the man said, "there are miles of beach and hundreds of starfish. Saving a few won't matter." After listening politely, the boy picked up another starfish and smiling said, "It matters to this one." And what I gain from this is, it begins with each of us. We all have a role in this very important aspect of healthcare to promote health equity and to promote culturally competent healthcare at the intersection of risk and quality with social determinants of health. Next slide, please.
And this isn't just John and my liberal altruistic leanings, although we are both liberal and strive to be altruistic. But we would argue this is all of our problems. Whether we invest in prevention now to counter the onset of chronic long-term illnesses that result from SDOH, or we pay later in emergency room visits, long-term hospital stays, and long-term prison sentences. We all pay in the end. And if we get to choose, we'd prefer that payment invest in giving people the support they need to thrive, rather than just struggling to survive while suffering under the conditions inherent to the social determinants of health.
That brings us to the conclusion of our webinar today. And on behalf of myself, Dr. Goldberg, Centauri, and RISE, I'd like to thank you for joining us today. Please get in contact with us if there's anything we can assist you with as you consider your role in ensuring populations that are thriving and not just surviving by addressing social determinants of health and health equity. Thank you. And we now have time for some questions. And so I will open the floor back up to Trey.
Thank you, Dawn, and thank you, Julie. It was a wonderful presentation today. We did have some questions come in. It looks like, Dawn, this one was directed at you. We hear a lot about Z codes and claims being the way to identify SDOH that relate to members. Is there anything else in the data that should be considered? It looks like you're on mute.
Dawn, you're still on mute.
Oh, there we go. I found the button. Yes, actually, Z codes are merely the beginning, because as of right now, many providers don't specifically screen for SDOH in the absence of a standardized tool for screening. It's important to start with identifying the high utilizers from a cost and volume perspective. Profile them by building lists of all their diagnosis codes and procedure codes present in their claims, and compare those to medical records, health assessments like HRAs and annual wellness visits, and quality measures. So this is a multifaceted approach. Then you can build a very specific plan to address the SDOH through plan benefit design and other risk and quality strategies that include appropriate KPIs and metrics to measure their success and their return on investment.
Thank you. Next question for Dawn as well. What kinds of screening tools are in existence for SDOH?
So HHS and all of the guidance that you heard me talk about on an earlier slide, which is a lot, thankfully, has not yet specified one as a standard. But the CMS Center for Innovation did develop a very useful one as they test the accountable health communities with that AHC model that I spoke of. Under the section 1115A of that Impact Act of 2014, CMS, of course, is testing whether screening for these needs is going to improve utilization and cost reduction. And they do have a screening tool. So if anybody is interested in taking a look at that tool, I can put a link into the chat where you can find it in all its glory out there on the internet.
All right, I have Julie. It looks like this one may have been directed towards you. How can we identify where a person is along the health behavior change continuum in order to tailor our messaging?
That's such a great question, because that's key, right? And there are some fairly simple tools for identifying where people are, but that's not where we stop. We need to understand, once we identify where they are, it is crucial that we then tailor our messages so they can be heard. Because what matters is not the information, but it's the right information for the right person at the right time to help them take action so that they can successfully change their behavior and then maintain that health behavior change.
Dawn, we had one additional one for you. Providers have enough to deal with, and they can hardly be expected to perform SUH screening. How can a health plan do their part to engage providers in this screening while minimizing provider abrasion?
That's a great question. And I actually have a presentation that is completely tailored around provider engagement because it is a critical part of a population health model. And I would venture to guess that most of the audience probably knows that. Many providers incentivize their providers to do this. And more importantly, they track the identification of SDOH by ensuring the results of a screening translates to those Z codes we talked about that are present on claims and documentation in the medical record. Provider education and engagement is absolutely necessary to ensure the success of these screening programs. And more health plans have staff whose sole job is provider engagement. It's not enough just to give providers a screening tool and then ask them nicely to please use this. There has to be a formal educational process to gain their buy-in and to implement a process to measure utilization of the screening and the translation of the screening to appropriate coding on the claim and in the record. And we are used to doing this, of course, in the risk adjustment world. Appropriate plan benefit design and case management depends upon this in order to produce high quality and cost-effective population health programs.
All right, thank you, Dawn. Julie, it looks like this one may have been directed towards you. Given the limited resources in a doctor's office and the reluctance of many at-risk populations to even go see a doctor, how can we get this message into the hands of our at-risk members?
That's a great question and perfectly follows on what Dawn just said. And here, it's great if we could get these screening tools into the hands of our providers, but technology can also be leveraged here because research has shown that the kind of high-risk populations who live at the intersection of these SDOH factors unexpectedly tend to be early adopters of technology, like cell phones. And so if we can leverage this technology through things like texting, apps, or even engaging games, these are going to be provocative, they're going to be less threatening, and they could even be geotagged to trigger specific messages based on their locations, like if they're near a market that has fresh fruit and vegetables. And again, this is about making sure that we're messaging at the right time to the right people so they can take action.
All right, and I did have one last one come in. Given the time lag between initiating an intervention and seeing a change in health outcomes, how can we tie a specific SDOH program to a specific change in health outcomes?
Yeah, this is the big question, right? It sounds so good to have this buffet of services that you can offer to all members. But as we have shown, I think, hopefully convincingly, it's going to be really hard to know if you see a change, what was the cause of that change? Because those interventions are very costly and we want to be effective and tailored and targeted in our interventions. So what we would argue, potentially using something like a suspecting engine that Dawn had mentioned, is that instead of this buffet of services to everyone, we identify a specific group who would most benefit from a specific SDOH intervention that would then target a specific health outcome. And then with these tailored interventions, if we see a change in that health outcome, we could more convincingly argue that it was caused by our intervention. But you don't want to limit yourself to just a health outcome because you also need to think about things like attitude changes, changes in process, so that you're giving yourself the best opportunity to measure the impact that you're having. So even though this is one of the most challenging things, if we could pull together a suspecting engine to identify our at-risk members, tailor an SDOH intervention to target them, and then measure changes in attitude, behavior, and health outcomes, we might be able to see the needle moving a little bit towards effective SDOH programs that have a real ROI.
Thank you, Julie. I had another one just come in as well. Do you have info on specific screening tools for SDOHs in behavioral health?
I think, Dawn, that one's to you.
So I don't know of any formal ones since my focus is not behavioral health, but I do know that I have looked at some online tools that are offered by specific health plans that they have developed to screen for, particularly for children, for behavioral health. So Julie and I can certainly chat about that and provide a more specific answer so that we can kind of give the best ones that we see out there.
All right, it doesn't look like we have any more questions unless anyone wants to get a last minute, or excuse me, last second inquiry into our speakers. With that being said, I just want to thank you, Julie, and thank you, Dawn, for today's presentation. Truly appreciate your contributions to the program. Special thank you to Centauri Health Solutions, their team as well, for sponsoring the program. Be sure to visit the Event Center at risehealth.org for all of our upcoming webinars and conferences for topics of this nature and other varied topics as well. As a reminder, we will send the slide deck in presentation to all participants within the next week at the close of the program. We look forward to hosting you all again on another webinar very soon. And thank you once more. So
Thank you all.
Julie.
Thank you.